Okay, so let's kick off. So just to say for those who have just joined us, this is being recorded and it will be on YouTube. So if you don't want to appear to the masses, then just turn off your camera. But let's launch because I'm always running late for these webinars. So I'm going to try and keep to time. I'm going to try and whiz through my presentation in half an hour. And then we have our guest speaker coming on from HCA Private Healthcare Hospital. So let me tell you how you can open your own private clinic in 3 easy steps. I promise it's just 3 easy steps. Okay, fine. So I think I've frozen. I'm frozen. Yeah. So what are we going to cover? So a little bit about us and about me, how we work, why is now the right time to open your own private clinic, a little bit about the private clinics and also a private treatment center. And we'll leave the questions to the end because I was watching through some of my webinars on YouTube and I just thought it was just chaotic. I prefer people to ask questions during the session so they don't forget and so I don't forget. But actually, on YouTube, when people are watching back, it's just sort of lots of cutting in, and I get distracted. So let's see whether you can just save your questions to the end or just put it in the chat, and then we can go through them. Okay. So who are we? So we're ThankStop. So ThankStop is the only digital and physical doctor on-demand service in the UK. So what do we do? So in a nutshell, we are business to consumer. So we match doctors with businesses who need doctors for their customers or patients. And we also give GPs practicing privileges in order to open their own private clinic. We're going to go into that a little bit later. But what do we really do? So we want to empower GPs to work flexibly and to be valued. We're building the largest network of primary care specialist clinics. So we can do sort of like an inter-referral type of service. So it'll all come clear. I'm so sorry, my computer's a bit slow today, my internet. So about me, so who am I? I'm Linda. I'm a GP. I CCT'd in 2017. I trained in Newham and my medical was in Norwich. And I feel like I've been a bit of an entrepreneur throughout my whole life. I remember when I was started, oh my gosh, in university, people were getting food parcels from their mums and dads, and I was getting like shoes shipped from China that I was selling on eBay. So it's been a bit of a roller coaster ride. I've had some experience in terms of I had my own skin clinic in Harley Street. I dabbled in properties where I was renting properties out. I've done teaching courses. I've done cosmetic formulation. So you can see there on the top right-hand corner, Fame Skincare Acne and Dark Mark Treatment Pads. So this was my skincare brand. In the lower sort of left-hand side corner, that's me with my doing my CPD courses where I used to teach nurses, pharmacists, beauty therapists, estheticians on how to treat skin of color. So that was my niche or my specialist interest. So I believe in failing fast and failing forward because that's the only way to learn is just to go and do it. And you can see here, I've had a lot of failures and a lot of lessons, and I've learned something from everyone. And that's kind of what's brought me here in order to help GPs open their own private clinics. Because before I was doing it for estheticians and people in the aesthetics industry. They'll come onto a course with me and we'll go through like a 3-month plan, and they will actually, by the end of it, open their own private clinics. So I naturally pivoted towards doing this for GPs. Yes, it was definitely more complicated, but also more rewarding. And so I just put everything that I learned with aesthetics into a general practice. And it's definitely been a journey and definitely been really fun. But we're gonna touch on that a bit later. Okay, so how do we work? So we work in 2 main ways. So we work as Uber for Doctors model, and we work as a private clinic model. So you can do one option or both options. At the moment, we're rolling out the private clinic model. So when you're under a private clinic, you automatically get access to the Uber for Doctors platform. And that's what we're prioritizing. So the Uber for Doctors model, it basically works similar to Uber. So the way you book a taxi is the way you book a doctor. So it's basically you sign up to our platform and you get pinged jobs based on your location and what you put as your specialties. So basically, let's say, for example, a patient can't get an appointment with their GP. They don't want to go to A&E. They don't want to go through 111. they'd rather just get seen privately. So they tend to go to their pharmacy, and pharmacy does something called pharmacy first. And that's why actually a lot of patients seek medical advice from their pharmacies, because actually the government has pushed a campaign that says, if you've got any of these medical conditions, then, see your pharmacy first, see your pharmacist first. So actually patients are very used to going to their pharmacy for medical conditions and for treatments. So that's why we've partnered with pharmacies in order to, if there's something that they can't deal with or something that falls outside of the pharmacy first criteria or sort of treatment or gateway, then actually they can signpost the patients to us. So then they can book an appointment, or the patient can go to the pharmacy, request an appointment, or the pharmacist can book it on their behalf. That request shoots out to all of the doctors on the platform. The first doctor to accept will see that patient online, or they can see the patient face to face in the pharmacy consultation room. The private clinic model, this is almost how we give practicing privileges to GPs so they can launch their own private clinic under our CQC. So it's not like we license CQC or they have CQC. It's actually they work under our infrastructure in order to launch their regulated services. So let me just tell you a little bit more about that and just change slides. Okay, so why are we doing this? Right, so you guys have all probably seen like the headlines. I think last month, they launched the, online access where they're giving patients access to request appointments or request services from 8 o'clock to 6:30. I don't work in like a GP surgery. I work on NHS 111, so it didn't really affect me. I didn't really see it. Well, I saw actually an increase in patients coming through to 111 when the GPs were just overstretched. So actually, it just shows that the general practice is becoming really, really overstretched and becoming unsustainable. There's a high number or record number of burnouts, and it's just not something that like GPs are happy working with. So you can see some of these headlines coming through. Practices forced to hire extra staff to manage online consultation. GPs facing contract changes after online access, workload increase. So the workload's increasing, the money's not increasing. So, GPs are getting a bit grumpy and they're looking for different ways to work. Now, this is Steve Taylor. So he's a spokesperson for National Association of GPs in the UK. Yeah, I think I got that right. So he's basically saying general practice is sleepwalking into a two-tier system where private care will be normal for many. And in the 90s, 7% of dental care was private. Now the figure is 75%. Today, 7% of general practice is private. So you can just foresee in the next 20, 30 years, 75% of general practice. So we look like we're following the dental care trajectory. And that's why it's actually important to start thinking, okay, do I like working this way by the traditional NHS, or do I also want to work as a private doctor? So I'm not telling you guys to quit NHS GP work, but actually some people want to work flexibly and build something for themselves for their future. Here you can see these headlines: a third of GPs plan to quit in the next 5 years due to burnout and lack of job satisfaction. There was the issue with the R scheme, so the additional roles reimbursement scheme, where actually the funding was ring fenced to hire additional staff, but not GPs, or not GPs within the first 2 years of CCT. So they're hiring the baby GPs or the less experienced GPs, and actually giving them really like crazy workloads where there'll be a PCN GP rather than actually fixed. I think actually when you first qualified, you need that support. So a lot of the new GPs were getting these kind of contracts where they were working amongst practices, and it was really just not settling for them, and they can't follow up patients. So there's a lot of job dissatisfaction there, and a lot of the other GPs, like myself, locum GPs especially, couldn't find work. So I saw this post by Jason New on LinkedIn, so I thought I'll just present it because it was very interesting. Actually, he's a not a GP, functional medicine doctor in Australia. So he actually mentioned that traditional general practice is dying. So I'm not sure whether you guys agree with this, like what your thoughts are. Maybe you could put it in the comment section. Most doctors have not realised it yet. There are 342 telehealth providers in Australia and New Zealand right now. That number should make every GP clinic nervous. Once upon a time, seeing your GP meant visiting your local clinic, the same location, the same doctor, the same chair. Now you can see a doctor through an app in 30 seconds, get a script online before your coffee order's ready, get an antibiotic and immunize at your local pharmacy. The traditional model of continuity relationships, I can't read that because something's covering it. You guys can read it. Anyway, so he says patients don't want to book for next week. They want care now on their phone with no waiting room, no hold music. And honestly, who can blame them? The problem is that most clinics still operate like in the 90s. Same system, same model, same thinking. The landscape has changed. If primary care doesn't evolve, it would just struggle. It will become obsolete. A modern primary care system is forming. So the future belongs to clinics that specialize care that were traditionally delivered by other specialists, that integrate digital health into their workflow, that collaborate with pharmacists, nurses, and allied health staff, and give patients ownership of their health information. That's super interesting. So it's basically saying that we need to bring general practice into the 21st century, and actually, people now we have this, on-demand type of ecosystem. So whether it's entertainment on demand, food on demand, like you can order anything through an app, and that's why people actually are tired of waiting. But what's happening with general practice, the wait list to see a doctor is getting longer and not longer, and that's why people are looking for alternatives. So I'll just go to the next slide. So I put this here because so we work with pharmacies, and they're our partners because we utilize their real estate, so their consultation rooms, in order to deliver the clinical services. But pharmacists from 2026, so from next year, they're going to transition from dispensing to clinical services. So from next year, all pharmacists qualify with a license to prescribe. So they're going more into the prescribing route. So we have to almost think, okay, where does that leave GPs? Because of course we're in an overstretched healthcare system. So actually, if the pharmacies are coming in, maybe the GP will be pushed out, as we saw with like the R's role, and we have to call a spade a spade. That is what happened. So we always have to think, okay, what is next for us? And that's why a lot of the GPs are niching down, developing a specialist interest and opening clinics, because these services are really, really needed. Have a look at the time. Okay. So you can see here, this is the rise in number of patients per GP. So I think 2016, it was around 1,800, and now it's 2,300. So that's an extra 500 patients for GP. So you can see actually the workload is getting higher and higher. The number of GPs are getting less and less. Here is a change in GP pay. You can see just a downward trajectory. GP pay is not increasing with inflation, and even I see, and even I experience, like I live in London, so to get a property on a GP salary in London now is practically virtually impossible. You have to kind of couple up and combine salaries, because actually our pay hasn't changed in decades almost. So we have to look for different ways to support ourselves, to support our families and our future. Okay, and this is about patient satisfaction, and you can see UK patients are going private to escape referral black holes as a GP. I think I just read an article the other day by Lang Wilson. I think I'm pronouncing that right. So the statistic was actually 1 in 3 patients went private this year. So that's 34% of patients went through either private medical insurance or self-pay for medical treatment. So that's a huge, huge number. Okay, so let's talk about our private clinic platform and how we work. Okay, so we basically work, as I mentioned before, almost like a practice in privileges. So I try to make it, because it's a bit complicated, but just to sort of simplify things. So under our structure, we have the CQC, so you'll be working under our infrastructure. So it basically means we have clinical oversight and clinical governance under for your patient notes, your indemnity. So we can basically cover your indemnity, we provide clinic support. The CQC is under us. Electronic patient records are included. So we have clinical oversight in terms of what you're writing by the patients, and also how you're consulting your patients. Prescribing software is included, so we can understand what you're prescribing. And with CQC, you have to do a number of audits just to make sure that the prescriptions are correct and sort of in keep, and appropriate. Sort of consent forms, we help you. So we work with a partner web developer that can get your website created within a week. And we work with a lot of referral partners, and we're going to bring on a referral partner from HCA a little bit later in about 15 minutes, just to tell you about some of the facilities in her urgent care centre. So I'll just sort of talk you through. I'm not sure what the next slide is actually. Let me have a look, and it doesn't happen. It lags. Okay, open your own private clinic in 3 easy steps. I promised you it was 3. So you literally just register and you pay your fees. I don't discuss fees on a webinar only because I put it on YouTube, and therefore it's evergreen. It's always going to be on YouTube, and the fees do go up each year and with inflation. So I don't want people to say, oh, but you said it was this much, and actually it is not. So if you're interested, just DM me. I'll put a link in the chat after this presentation, and then I can let you know what the fees are. So you just need to register, upload your compliance documents. I'm sorry, there's about 22 compliance documents. We're very hot on compliance. You can't go live on our platform unless you're fully compliant. And that's probably the hardest bit. And then get a website. So just register, compliance documents, and get a website, and you're up and running. So super, super simple. Okie doke. So so this is our first amazing cohort. They've done really, really well. So we have 12 doctors here, and they've actually opened lots of different types of things. I've been so impressed with kind of just the energy, and also just the amount of experience they have in really, really different areas. So we've got a menopause management doctor. We've got a doctor that specializes in diabetes, and he's excellent. He sort of halves your HbA1c within 3 months, with just oral medications and lifestyle management. And so no sort of insulin, no injectables. We've got really interesting women health and aesthetics, GP and clinic, burnout and prevention, and lifestyle medicine. So loads of different things. So it's all just to follow your passion. As GPs, as we're sort of working, we tend to lean towards one type of have one or two types of specialist interest that we lean towards. You can be in a GP surgery and they always send you this type of patient because they know that you're good at it. So with me, I got all the derm patients. But when it came to menopause, I was like, it's really not my strong point. So I would send to a women's health GP, or someone who's really good at managing menopause. So it's almost just to discover what you like doing and working the way you like to do and on your terms. And that's what we really want to support. It's really amazing just to see GP kind of just coming into their own and just kind of work how they want on their terms, and get a lot of satisfaction, because you get more satisfaction doing what you like than kind of covering a whole host of things. And some GPs actually want to just do general GP services, but privately. We have, I think, about 3 of them in the cohort that just done sort of private GP, and they're getting patients a number of different ways, and they've been super creative in terms of how they've got their patients. So this just goes to show that we're all really in the same boat, and you just literally need a little bit of support, in order to, and just encouragement in terms of opening your own private service. Okay. So what actually happens? So once you've paid the fees, you've uploaded your compliance documents, what's the other one? You've got yourself a website. So we basically do 4 weekly masterclasses. So they're about an hour and a half. And we just go over a number of topics just to make sure that we're all on the same page. We don't really want anyone being left behind. We just, and if I see someone that's kind of like gone a little bit quiet, I'm like, hey, what's going on? And it could be just life is life in, or it could just be something like they're struggling with their website, or they're struggling with their consent forms, or something. And there's always somebody to help in the community or in the cohort. So I definitely don't, say that I have all the answers. Yes, I have a lot of experience in business and clinic startups, but actually there's people that have way more experience than me, and like websites and coding and marketing. So we just kind of lean towards our strengths and come together as a community and cohort and support each other. So we go through 4 weekly masterclasses. We make sure that you get your own indemnity. So we work with our indemnity partners, and you just sort of apply, but you're applying under our corporate scheme. So it's not an additional cost. They just want to make sure that they know who's working for Tankstock, and they do, I think, a few checks just to see that you are who you say you are, and there's no sort of restrictions to your license. And then they give you a certificate. Once I see that certificate, I'm just like, okay, that's one of the compliant documents that are uploaded. Then we give you your logins. I'm really sorry, because we're a new startup, things are not talking to each other. So all the technology is not talking. There's no API integration. It's just like a technology situationship. So you have to get the login to the electronic health records platform, the electronic prescribing platform, the laboratories where you order your bloods and all your pathology, and also radiology. So you'll get all those logins. You'll get logins to our policy portal. That's where all our policies are. So you'll never get lost. Like, even if you're in clinic and you're like, oh gosh, what is a prescribing policy? Are we able to prescribe this or not? No, you just go into the portal, because everything is there, and it's super important. And that's kind of one of the areas of like clinical governance and oversight, that actually everyone's on the same page and everyone knows where to go for help, and it's not sort of randomly emailed, and you have one version and somebody else has another version, and someone bounces or goes to junk. No, we actually have a policy portal that you can just refer to, whether it's price list, whether it's how do I contact radiology. All of that information is there. And then lastly, we have a community that provides support. It's really actually quite lonely going through it by yourself, and it's quite scary actually, because you're always thinking, am I doing something wrong? Is this correct? Oh gosh, I got my first patient, what do I say? I literally remember, when was it, probably like 10 years back, when I got my first patient. It was in aesthetics. Oh my gosh. And you train and train and train, and you collect all your certificates, and then your first patient's there, and your hand is shaking. Oh my god, this poor woman, I was doing the Botox on her. I was just like, she was so kind to me, but my hand was shaking, and I was sweating. But really, as GPs, you kind of know your stuff. Sometimes I just say, you don't need any more certificates, because the best way to learn is just to kind of throw yourself in. It's not like we're practicing on patients, but that's how we learned as F1 doctors. We've done 5-6 years of med school. We've done all the exams, but then on the wards it's completely different. By the end of the day, you've got this crumpled up list of things to do with the boxes that you tick off, and it's completely different from the theoretical that we learn in med school. So I always just say the best way to learn is just to go for it. No better teacher than experience. Okay. So things we cover in the course. So this slide is very overwhelming. I just noticed. So I just kind of picked out some stuff. So not to kind of scare you guys, but just sort of just things that we cover to make sure that you're up to speed. But it's just really the practical things. So ignore the kind of background noise, as long as you've got your website where you can actually book patients in, because otherwise you don't have a business, you don't have a service. So a booking site, a price list, so people can see actually what things cost. Very good to be transparent. I think my pet peeve is when people put their services, and then you have to call them for the prices. I don't even bother. What do you guys think? Some people you could see actually a call for prices. I just jump off that website and go to the next person that actually has their prices there. Because sometimes you don't even really trust whether the price has been bumped up for you, or actually, that is the real price. Even with, I'm going off on a tangent, whenever I'm booking a service, I never say I'm a doctor, because I think everyone thinks, the general public thinks doctors are really rich, but we're not. We're actually not. So I always say oh no, this person or this type of I never say I'm a doctor, because I'm just worried that the price will just jump up tenfold. So yeah, coming back to it, booking site, price list, a list of your services, what you're offering, a way to take payment offline and online, a website, and partnerships. So just developing partnerships so people know who you are and what services. So it could be just going to your local pharmacy and say, I'm Linda, I do aesthetics and skin. Do you ever have patients that come in that want have this issue? If you do, here's my number, or here's my card. Can you just call me, or you can book me in 3 hours on a Saturday, and you can book those patients in, and we can have some sort of revenue share. So just make people aware of what you do, because if people don't know what you do, No one's ever got to call you. And some people feel like, oh, I'm not going to tell anyone because my idea is very unique and I don't want anyone to steal. Like, ideas are not unique. Even my idea, this Uber for Doctors, like millions of people have probably had the same idea. So ideas are not unique. It's all about execution. So just shout about your services and what you do. And that's just the best way to get discovered and to get going. Okay. I put if you're not embarrassed, I can't remember who said this. If you're not embarrassed about your first product, you launched too late. So what does that mean? So that basically means if you sat there perfecting, and then you're really happy with your website, well, it's too late because actually your competitor that launched with like a subpar website has already started getting the clients that would have been on your website because you've been, over analyzing and analysis paralysis and just trying to perfect. And that's kind of one of the strengths and also the weakness of a GP. I think we are perfectionists. We want to make sure that we have all the certificates, like everything, all our T's crossed and our I's dotted, and everything in order. And then we're like, yes, I'll launch. And it's like crickets, it's like tumbleweed, like it's not like build it and they will come. So you just have to launch, and you launch before you've launched, really. You just get your website up, just get the customers being booked. As long as you're safe, and that's why we make sure that actually you're compliant, you're insured. We cover all of the kind of operational aspects of it. So as long as you're operating like safely, which you all would be, you're all GPs, you operate in the NHS anyway. So just launch. You don't have to. Some people say, oh, I don't have a specialist interest. Maybe I should just wait and get, certificate for another billion months. No, just go for it, because actually as GPs, we already have the understanding and the knowledge, and you don't have to do so much more theory. It's already there. So even when you see on the RCGP website, even sometimes people are we have a doctor that's developed her own ADHD clinic, and we're working with a partner psychiatrist, consultant psychiatrist, who's actually going to roll out a teaching. It's going to be a short course, so it's going to be over 2 to 3 days on how to assess and diagnose and treat sort of ADHD and other neurodiverse conditions. And it's a really comprehensive course. It's excellent. I've had a look at the agenda, and he also offers like training and support and mentorship. So he's really, really excellent. So sometimes, okay, yes, you can go on a course, but even after that, like, what happens? You're on your own. So sometimes just launch, go for a course if it makes you feel a bit better, but don't spend too much on it, getting diplomas, this and, qualification that. Just go for it, because actually your patients teach you more than a lot of courses do. Okay, doke. So things you can do under our CQC. So we are regulated for the regulated activities is treatment of disease, disorder, and injury, and also diagnostic and screening. So you can do online consultations, in-person consultations, home visits. You can work anywhere in England, because CQC is just in England. It's not in Scotland, Wales, or Ireland. It's not throughout the UK. See any age. So we're able, we're covered to see any ages from 0 to over 100 years. So age is not an issue. We just say that actually, just for patient safety, children under the age of 10 years old, they're seen face to face, because we all know with kids, they can look fine, and sometimes you just have to prod and poke and take temperature and take observations, and it's a completely different picture. So we just want to make sure that actually to ensure that patient safety, that we see under 10s face to face. Any GP related clinic. So it's amazing being a general practitioner. We're generalists and we can have specialist interest in different things. So yes, we can do like we can start a clinic, which is a GP clinic, but then otherwise you can go into your niche area. And you're also covered for aesthetics. So our indemnity partners, they cover anything medical or GP related, anything aesthetics, including IV drips, and also one of our cohort, they asked for them to cover, doing talks. So they might go to maybe a corporate company and give it a talk on menopause, for example. So yeah, sometimes health information, someone can say, oh, you gave this talk and I went and done this, and I want to sue you. So even for things like that, they're covered. Our indemnity partners are super flexible. Okay. So things that you can't do under our CQC. So I say prescribe risky drugs. We all know with online, it's patients can be tricky. There could be a lot of drug seeking behavior, especially with an online and private service. So, they could be going to one private service to another private service, another, and just getting sort of controlled medications. They could be addicts. So we want to make sure that actually our CQC, we don't prescribe any, I think, class A to C and schedule 1 to 4 medications. I'll double check that. It's on our prescribing prescribing policy. It's only for GPs because that's who our indemnity covers. No secondary care type services. So nothing that is very like invasive, because we just shouldn't be doing that as GPs anyway. Also, because I've seen other companies, it's always good when you open up services just to see what other companies are offering. It's also interesting. And other companies, they're naming no names. Sometimes they say, yeah, we can sort of give you practicing privileges, but you also, it's buyer beware because some of them are quite cheap or low cost, but they don't provide access to their policies. They don't, give you true clinical governance because usually they'll say, yeah, just get this electronic health record and you'll have your own login and your own password. So how do they know what you're prescribing? How do they know, your consultation notes? Are they doing audits? And that's all part of CQC. So always make sure that actually when even if you're going with another provider, just make sure that you've done your due diligence. Okay. Next slide. Okay, so setup. So I'm going to quickly whiz through this. I don't know how many slides I have left, but I'm sort of running a bit late. So in terms of setting up your own CQC clinic, and we really want to empower GPs to open their own clinics. I think it's amazing. There's nothing, more empowering than actually helping patients and being there to help patients that need your help in terms of their health or their medical conditions. It gives you like great great satisfaction. And sometimes in the NHS, there's certain constraints. So there's things that we can't do even if we wanted to. So that's why actually I feel like there can be, I think private services complement NHS. So it's always good to give that option. So if you were going it alone, it costs quite a lot, and we actually want GPs eventually to fly the nest and go it alone. But we almost act as like the pilot phase, like the testing phase, where you think, okay, is it right for me? If I practice, if I go private, is this right for me? Would I get patients? It takes a long time to get your first patient booked in. It's not going to happen overnight. It might take a couple of months, and you don't want your overheads to be running, thousands of pounds a month whilst you're waiting for your first patient. So you want to almost practice as leanly, is that a word? As lean as possible. You want to get up and running as quickly as possible and as lean as possible, so as low cost, just to make sure actually it's right for you. So because otherwise there's a high cost to opening when you go it alone. So CQC registration fee is around £2,000, depending on how many activities you're regulated for. So it can differ. So setup and compliance. So to get a CQC consultant, it's around 5,000. I think actually that is quite low. Or I think sometimes it's 6,000 to 8,000 like these days. For them to take you through the whole process and set up your policies, your documents, SOPs, etc. To rent a premises, I put 2,000 a month, but you have to, that's in London, that's quite low because you have to also think about business rates, like utilities, rents, when things go wrong. You have to think about all of those things, and you're basically locked in for a good 12 months if you're renting your own clinic. Medical equipment and furniture. As GPs, we actually don't need so much, but actually, if you're starting your own clinic, you'll need to furnish the clinic. And so it's not really the medical equipment; it's mainly furnishing the clinic. Medical indemnity. I was quoted initially £1,200 based on 2 sessions per week. And so it was actually quite expensive. It was back to the old days when actually, if you remember, I was doing 10 sessions a week, and I think I was paying about £10,000 for insurance for the year. So it was actually quite high. It's only now with like the Crown indemnity that's when like our costs came right down. But with private indemnity, it's basically the same as it used to be, a few years back. Admin and booking system, marketing, and the time to launch, I thought 3 to 6 months. That's being conservative. Really, it can take 9 months, 12 months. I know our CQC was a little bit different, a little bit trickier. So it actually took us 14 months to get our CQC. So you can even see us on Companies House, registered 16th of January 2024, and we got our CQC August 2025. Bit of a nightmare, but I get it because they want to make sure that you're safe. So we were declined like twice. We had to like adjust things. They'll ask you questions like how are you going to be safe, effective, well led. So all of these things, and you have to have the right answers, because actually at the end of the day, where there's patients, it's not like we're just setting up a corner shop. It's patients' lives that we're dealing with, and we have to make sure that actually the services we are providing are adequate and excellent, not adequate. So on average, let's say the total cost might be around 30,000. With us, then it might be around 1,200, and that's about 4 to 6 months worth. Okay, so let me click on the next step. Okay, so what time is it? Nearly there. Okay, not too bad. So we are going to be talking about our private partners. So we work with a lot of private partners, whether it's radiology, laboratories, like pathology, and also referral partners. So sometimes, there's things that we can't do, so we need to refer them to the appropriate clinician or the appropriate service. So we work with a number of healthcare partners, and one of our healthcare partners is HCA Healthcare, and we've got Dr. Bumi on with us. I'm sure she'll make herself seen once I've closed down my presentation. And she's going to just take you through sort of some of the things that HCA offer. So HCA is Hospital Corporation of America. So it's like a healthcare provider that started off in America, but also does so US and UK. So they operate over 180 hospitals and over 2,000 care sites worldwide, and they employ many staff. Actually, in the UK, they're the large provider of privately funded healthcare. Their hospitals are beautiful. Like urgent care centers are amazing. Like you feel like it's like a hotel, and they really have great quality care, and it's super affordable and efficient. So they've got hospitals in London and Manchester, but then they still have outpatient and diagnostic centers, and they have specialist unit for things like cancer care, fertility, also. So they have a number of have a network of facilities. So urgent care centers. So yes, I think I saw Dr. Bumi on LinkedIn doing an amazing video and just telling the audience about the urgent care centers that HCA provides. So there's one that has recently opened in Birmingham. I think it was in April, the Harborne Hospital. It looks really fantastic. So when I reached out to her, I said, "Oh, I didn't know urgent care centers offered X, Y, and Z." And she was like, "Yeah, this one does." I was amazed. It sounded like A&E, but not the amount of things that they can do. So it's really important to understand and just be aware of the facilities that we can, signpost our patients to, and the patients can access, because it's definitely something that I didn't know. So she's here to talk to you a little bit about that, and also give you some case studies. So and patients, they lean on you, they trust you as their clinician to say, "Doctor, what do you think? Where should I go?" And sometimes in the NHS, before I got into private practice, I'll be like, "Oh gosh, I don't know, just Google it." Like honestly, like just Google it. And yes, we shouldn't be referring, because there could be conflict of interest. But when you're a private doctor, it's something different, okay? Because so you can just be aware of the facilities and say, actually, I know this hospital does this, or I know actually you can go at 7:30 to this hospital and they'll be able to treat your chest pain. So let me stop sharing, I think just at the right time, because the computer's frozen. Dr. Bumi, are you there?
Yes, I'm here.
Excellent.
Hello.
Excellent. Yes. Brilliant. It's all gone to plan. Should I stop sharing and you share, or do you want me to?
No, let's leave it on. Let's leave this on.
Okay.
Yeah, thank
Okay,
you.
fantastic. No problem. So let me, oh gosh. Oh yeah. Perfect. So you can go for it. Just let me know when you want to change
All right,
slides.
wonderful. Thank you so much for inviting me today, Linda. I really appreciate that. And good evening to everyone. I apologize, I'm at work, so somebody might pop in. They might just want to ask a question, but I'll be as brief as possible. Dr. Linda had explained about HCA hospitals everywhere, but this talk is mainly about the urgent care centers. So as private GPs, it will be quite daunting to see a patient who requires urgent care or they're acutely unwell and they would benefit from, urgent bloods, investigations, and then you have to end up sending them to A&E. It would just forfeit that, considering many people don't want to go there now because of the very long wait, the quality of care, and what have you. So these urgent care centers by the HCA hospitals are quite very handy for something like that. There's a fast access to a GP with triage patients within 15 minutes. Most centers are in London, as you can see on the screen. There's Portland Hospital, Princess Grace Hospital, Leicester Hospital, Wellington, London Bridge, and there is Harley Street. I think that's mostly for consultation, but the one in Harborne Hospital in Birmingham recently opened in April, and we run the same kind of services back in London. If we go to the next screen, I don't want to talk ahead of myself. Yeah, thank you.
Okay.
Thank you. So common conditions we see, I mean, there's no point going through this one after the other. Basically, everything A&E sees, apart from acute stroke, acute MI, brain aneurysm, severe trauma, and mental health problems. So anything the patient has, chest infection, abdominal pain, urinary tract infection, wound care, they fractured something, they sprained something, they're not sure it hurt somewhere, they just want to be sure it's okay. Headaches. We see non-pregnancy related issues in women who are less than 20 weeks pregnant. But even if it is not a pregnancy related problem, but they're above 20 weeks, because of the possibility of having to have a core care with a gynecologist or obstetrician, we don't see them. So basically, anyone unwell, we see sepsis. I'm going to share with you briefly the kind of cases we have seen recently where ALS trained, we doctors working here are ALS trained, and we're able to manage as many acute problems as possible. Can we go to the next screen, please? Thank you. Right. So yeah, this is about us. Anyone above 18, we do not have pediatrics services yet. I think there might be something coming up. And even in London hospitals, I think it's only a few of them that run pediatric private care, urgent care centers. It's a walk-in. Patients call in to see if they can get an appointment. No, you don't need an appointment, just send the patients in. We have lots of investigations, x-rays, ultrasound scans, CT scans, MRI scans, blood tests. So our blood tests, most of our blood tests are by point of care. So the machines run them, and within 20 minutes, we have all our results to make decisions, including CRP, inflammatory markers, amylase, TROP, D-dimer, liver function tests, kidney function tests, glucose levels, CK, all those tests are within 10, 15 minutes, results are out, and then we can make a decision. That most of the other ones, like routine checks, like thyroid functions, HbA1c, all those ones, we have to send them to the lab, but they all come back within the same day, depending on what tests they are. And then that's our contact number for general inquiries. If you go to the next slide, I just want to run through, I think, yeah, so exclusion criteria on top of my head, going by our standard operating procedure, these are the ones that I've mentioned them earlier. So anything 999 ab initio, patients think they're dying or there's a massive bleeding, it's a 999, we don't see them. If patient is unwell, paramedics have confirmed through their own ECG that's an acute MI, or it just really looks like it, it's the hospital. CVAs, fast symptoms, anything like that is hospital. Trauma with multiple injuries have to go to trauma center, and thankfully we're just next door to them. So not saying that we can't see, for instance, if a patient walks in with chest pain, we will still see them. But if the ECG and the tropi suggests is MI, then we have a procedure whereby we call the paramedics to come and transfer the patient to the hospital next door. So if we happen to end up patient just walking, they don't know what's wrong with them, but they have any of this, we are able to safely transfer their care. The advantage of seeing us first is that they will then they don't need to go to A&E. We can refer directly to the registrars or the people in charge of on call to say this patient has been seen already. These are the results. Can you please take them over so they don't have to wait in A&E? So either way, if they end up here, they still have that advantage. But if it is any of this issues, like I said about the pregnancy and children, then it's the hospital. Now we go to the next slide, please. Thank you. Right, so some case studies, just so to be aware of, okay, what exactly do we do? So chest pain, there was a particular gentleman he had a normal ECG tropi, but chest was clinically cardiac sounding, and then so some of these patients were able to, for instance, if you have a patient like that on the NHS, you refer them to the chest pain, rapid access chest pain pathway, which can take 6-7 weeks, and then they do all these investigations. The advantage of being seen here is we can offer them those investigations, like these are the things we would need to confirm this is what you have or why you even have this pain. Even if it is not an MI, it can show us any other thing or most other things that might be wrong. And then patients are happy when they know the prices, they're happy to pay for it. So eventually, CT angiogram confirmed they actually had a blockage and they had a stent in the same day. We were able to network with most of the consultants that run outpatient clinics. Outpatient clinics, we share the same flow with them, and we're able to transfer patients there for complete package of care. There was another lady that was referred to us from a private GP surgery here in Birmingham with, they thought it was a 3rd-degree heart block, but when I saw this, I knew it was complete, but thankfully it was a stable complete heart block. She was still going around, going shopping and everything. We called her in and we were able to arrange pacing for her. So transcutaneous pacing initially, and then she was paced in the theater. We just called the team, the physiologist, the cardiologist, everybody. Within 2 hours, she was paced. The next morning, she went home. I had a patient who had nephrectomy as well, who had double retention, both fecal impaction and urinary retention, but was clogged. We were able to catheterize, irrigated him here, and then transfer him to the ward and handed him over safely to a consultant urologist. Advanced duodenal cancer in a 24-year-old boy. We were able to diagnose that and send that to the ward. Complete bowel obstruction, NG tube, everything, manage patients acutely. Let's go to the next page. I think there is the next page, please. Thank you. Right. So to round that up, those are the things we do. So like I said, it's like a mini A&E. So if patients really need an AcuCare and you don't think they can wait for your normal routine bloods that you would ideally ask them to go and do, x-rays that can wait till they have it done and reported, then that's where we come in. Common conditions come in. For instance, if a patient comes in with an abdominal pain, they have abdominal package. We have abdominal pain package, chest pain package. With the chest pain, they do tropi. With the infection package, we do blood cultures and VBG. With pulmonary embolism or DVT package, we have D-dimer. So they all have full blood count, urinase, CK, basic in all of them. Abdominal pain has urinalysis in them. So they come, because if we price those things individually, they come at a higher cost. But when they're put together as a package, then it works out cheaper for patients. So depending on how far, these people are, they're private patients, they are anxious about their health conditions, they want answers where NHS can't give them. And they have insurance. If they have insurance, another thing I wanted to mention is if they're insured, it's even better for them because we can bring in a consultant sooner And then before they have all these fancy investigations, the only thing they have to self-pay is the urgent care services. But if they're needing MRI scans, admission, outpatient consultant review, we can get that consultant in early and they can submit that name to the insurers and then they can get an authorization code and they can have all the treatments they want. So that's the kind of service that we run here. So these are the examples of prices. There are other things that come with different prices but we have the prices that we work with. Please go to the next page. I think we only have one or two more. Right, so one more thing I just want to mention. So we also run acute admission service. So this is not urgent care. But for instance, you're called out to home visit, maybe you do concierge services as well. You go out, see a patient, long lie, or they have possibly fractured something, or they're very frail, or they're unwell, and they have money. They can call the concierge team and you can arrange transport. They arrange the consultants that will take their care on, bring them to the hospital on admission. Nurses are ready to see them. We have resident doctors who are ready to see them and they can start their care. So even if patients can't come out, maybe they're housebound or they're fancy, they just really don't want to go through the stress of coming out of their house, the acute admission services are the ones for them. And they also do this service they do inter-country transfer. For instance, someone travels to the US on holiday, broke their leg, they need to be transferred to the UK for further care. They do this as well. So anywhere, if they want to come from Wellington Hospital in London to Birmingham for proximity to family members, they can transfer that patient. So the person in charge of our marketing has asked me to mention this as well. And I think it's a very good service. We work with them sometimes if they think the patient will benefit from some form of care before they get to the ward. But that's something as well that I thought, if you're going on private care, you might end up having someone like that who can benefit from that. And I think the next slide is the last slide. Can we go to the next one, please? Thank you. Yeah, so this is about the acute admissions. They have their own exclusions as well. Those are the services: respiratory, cardiac conditions, hepatobiliary, liver, GI, neurological, general medical conditions. That's their number. So all you have to do is call that number, give them information, then the admissions team will kick in. They're very, very efficient. They have the transfers. They have helicopters for helicopter transfers as well, if needed. And then, yeah, and I think that's about it. And again, those are the insurers that they mostly work with. So again, it's usually the insurers that come in with this kind of thing because I think it's a bit pricey. I think that's me done. The last two slides are just if you have any question, and I'm supposed to have my other colleague too. The two of us on this service. Another doctor will be resuming maybe next month. I think she was meant to join me to answer questions together, but that's fine. She's not here. But yeah, if you have any questions in the next few minutes, I'm happy to answer. Thank you for listening. Thank you very much.
That's excellent. Thank you so much, Dr. Bumi. And I think in our first conversation, my mind was just blown with all the services and the facilities that you have. So, I saw things like, pulmonary embolism, DVT, you guys can manage that because, I think with private healthcare, it had this stigma of being for the posh people or only for the rich people. But actually, even me, I'm from a working class background and my three sisters and my mum all have private healthcare. It's only me that doesn't have private healthcare. So actually, more and more people are having private healthcare or going towards sort of a self-pay. So that's super interesting that you offer that. And I think, private healthcare, when they thought, okay, it's a bit of a dirty word, oh God, private, sort of greedy private healthcare system, but actually it's an option, isn't it? And people don't mind paying, especially when it comes to their health, and so you have to give them all the options for them to make an informed decision. So actually, I didn't realize all of these services existed, but actually my patients will thank me for it if I say, rather than go to spend 10 hours in A&E, and people get so frustrated because even on 111, when I have to try to signpost people to A&E, I actually apologize. I actually say, I'm really sorry because I know when they get there what they're in for. You could have like your arm hanging off and you just sit there for like 8 hours. And when you're in discomfort and when you're in a state of dis-ease, you would rather just yeah, that's a good question. You would just rather just have it sorted you know, and you know, you can't put a price on life and health. And so it's really good that we know as doctors, especially as private doctors, where we're signposting these people and to be aware of what actually what facilities exist. So thank you so much for coming on. I think we have a couple of questions in the chat. So I might just steal you again for about a few minutes before I know you're working. So let me just steal you. I think someone came up. I just want to ask your questions first. So the price list needs to be more comprehensive. Is it the first question patient asks and it takes time to obtain authorization? Does the patient pay the specialist if they see them acutely? Does the cardiac package include the initial £120 fee? So you can see in the chat, Dr. Bumi.
Yeah, I can see
Yeah.
the questions in the chat. So this packages, to be honest, the way it works out, let me do it this way. So we have, you can't see it, but we have the list. What I would do is possibly take a picture and send it to you. So when people, that's to give them a rough idea. The one that I put on that Microsoft PowerPoint is the one people will see online, but actually it works out the same when they come in. We tell them this is a consultation. If the patient has an ECG and they have chest pain package on this one that we have is the blood test, but then when we add the ECG onto it, it works out as the same that I'm showing you on the PowerPoint. So there is another prices that we work with when we get here, but for security reasons, I think they haven't put that online. The one you have seen on my presentation is the one if you Google Urgent Care Center Harborne Hospital in Birmingham, that's what you will see. But actually, people don't need to do all of those things on the package that you see, because when they come here, if they don't need a certain thing, we don't necessarily need to do it. So doctor's consultation is already, to answer the last question, is already included in all the packages you've seen on the one I've shown you. But then if I see the ECG and I report it, it's not a cardiologist reporting it. My own price is different from if it's a cardiologist that reports it. And because I can report many ECGs, it works out cheaper for them. Do you see where I'm coming from? And then patients can come, the ones you're saying is not included, scans are not included in them. And patients come in and say, oh, I just have a little sprain in my knee, I want an MRI scan. You know, they can pay for it, they do it. So it's easier to show them that, to say most of the things that they would have, but there are other costs. That's why the last line on that page says there are other things that would incur further charges. And not necessarily do we do packages the way it's been seen online, because some people can do without a certain thing. Fracture, on the one you have seen, the fracture package, a lot of people come, if it's not fractured, you don't need the boots. Meanwhile, the package already has the boots, the price for the boots included. If they don't need the boots and they just sprained it, I won't give them a boot because I want them to walk on it. So it's very, very, I know it's a very tricky way to say, well, this is a rough price, but I think the basic thing they need to know is there is a doctor's consultation and there are charges for them. And if they're insured, it's better. If they're not, it might just be best for them to go in there and see for themselves. People come in, they can't afford it. We tell them the price they can't. And then they go, you know, it is what it is. A lot of people are still out there that still, you know, could benefit, but they don't have the funds for it and they're not insured. So, yeah, I'm not entirely sure why they didn't put the comprehensive list, but that's what the hospital has put online, and that's what I've shared here. But there are other things on the list, like wound package, wound dressings and everything. And I'm sorry, I think it's the uncertainty that puts people off if they're self-paying. Even if they're insured, they don't know what would be covered. Yes, so anything, so the point of care test and the doctor's consultation will not be covered by any insurer. They don't. We have worked with many of them on the service. They don't, and that's why I said that when we see that this patient will benefit from an admission or they need a scan, if they come in with abdominal pain, by the time I've taken history and I've examined the patient, I know what the case is. Is a gastroenterologist I need, or is a gen surge that I need, upper, lower, colorectal surgeon, trauma and orthopedics. I bring them in as soon as I've finished examining them. I think you will benefit from admission. You're insured. If I bring this consultant in, you can talk to your insurer and then your insurer can fund the rest. So all the MRI scans, admission, doctor's review, the insurers take that over. So if that would clarify things for you, I don't see any reason why you can't have the list, but it's about 4 pages of prices. So if I can leave that with Dr. Linda, and then if you're registered with her, you're up and running, it's something you can be aware of. It's not secret, but it's just too long for my PowerPoint presentation. The price list needs, does the patient pay the specialist if they see them? So yeah, if they see the consultant, they all have their prices. So each consultant will tell you, for my first review, this is how much. And if I come on the ward every day to see you, it's the certain price. Most of them is between 200 and 300. I've not seen anyone that charges more than 300, and I've not seen anyone that charges less than 200. So that's 200 or 220 or 250 or 300. That's how they charge, depending on the specialty. How are chest pain patients stratified pre-TROP and pre-ECG in order to direct STEMI or none to our EM colleagues? So again, if they come in with chest pain, they're stable when we've done the OBS and we do TROP, we do ECG. If the TROP comes back raised, we call paramedics for them. We don't say because it's next door, you can walk over. So even if, unfortunately, it's the ambulance services, if they take 30 minutes, we just have to keep stabilizing the patient. If they go into cardiac arrest, our ALS kicks in and we start to do resuscitation until they come. So the protocol is you keep them here until paramedics come and transfer them over. For the patients, the case study that I shared, whose ECG and TROP were normal, we just suggested, look, if you have this pain on the NHS, we would refer you to chest pain anyway, and you will have these investigations. If you're happy, you can have them done. So he had that done, and he had blockage, and he needed a stent, and it was just a complete package for him. So again, it's very difficult unless we have the numbers on our hands. If they're stable, we introduce further tests for them. To them. I think I've answered up until there. So let's go back down. Okay, yeah, it's just private clinic. Yeah, so yeah, it would be helpful to have the list. I will drop that with Dr. Linda. I think I have answered all of the questions.
Thank you so much, Boy. Yes, I will let you go now because I know you're a busy bee, and I will jump on to it because I think the rest of the questions are for me. But no, it's a pleasure having you to talk to our clinicians today and just increase the awareness of your services. I think actually, it's a fantastic service, so we definitely be partnering with HCA, and we now know sort of the referral pathways, and if in doubt, we can just pick up the phone and we've got that number, so we'll probably flag that number. Thanks so much, Bumi.
Thank you for having me. Thank you, everyone.
Thank you.
And good night.
Good night. So in terms of questions, so someone's asked, for private clinics, how can the location be free? So for private, I'm not quite sure where this has come from. So for the Uber doctor, the pharmacies are partners, so they don't charge us to use their consultation room because we work in a partnership. So we will see the patient, consult with them, and we tend to ask the patient, okay, can we send the prescription to the pharmacy that has referred you? And most of the time they say yes. So they get the revenue from the private prescription, and they refer our patients, and that's how we work in a partnership. In terms of a private clinic, that one is not free. You have to negotiate with your pharmacy. Some pharmacists or pharmacies actually say, yes, actually, because a GP increases the, how do I word it? To have a doctor in a pharmacy, it just increases the, you guys know what I mean. Increases the, what's the word? It just kind of makes you stand out, that you offer different types of services and sort of high-end services. So they actually say, yeah, just so they can say, yes, we have a doctor or pharmacy, we can offer you this room free for 3 hours on a Saturday. So it's all about negotiation. But for the Uber doctor, it's free. For the private clinic, it's up to what you negotiate. And they sometimes, in London, the going rates are about £10 per hour to £15 an hour. And a lot of the pharmacies now, because they are diversifying, they are rebuilding their clinics, their pharmacies, so they actually have a number of consultation rooms. So of course they would need their own consultation rooms to do, their services that they offer, but also there's usually another one free. And minor surgery and steroid injections not covered. Yeah, so they are covered. Minor surgery and steroid injections, whether it's for joint injections or even Kenalog for Haver injections, they're covered. does video consultations for patients outside England, such as Scotland, and come under CQC. It's not, no. So CQC, so a bit of tricky, because our insurance or our indemnity allows you to practice throughout the UK. But CQC is only for patients in England, and also the doctor needs to be based in England. So in a nutshell, it's just England, even though technically you can see patients for your indemnity, but with CQC, we're only regulated to provide services for patients in England and make sure that the doctor doing those regulated activities are also based in England. How can I find out if there is a pharmacy, if there's a partner pharmacy or clinic near me? So is this for Uber? Because I guess you don't tend to find out. So it's a good question, because Uber Doctor is just that when you're going onto our platform, you put in your postcode. So whenever there's a patient that's, patient request that is near you, it'll only come up to the doctors in that postcode area. So you can almost like put on the platform, okay, I want to see patients within this postcode within, I don't know, 10 miles radius. So it will ping to you if you're in that location. So then you'll know that the pharmacy is our partner pharmacy, because they have to sort of on board with us. In terms of if this is about the private clinics, then you can just bring them on board. It's very strange, because actually we always work with pharmacies, whether it's like from med school, like in my med school, Norwich, the pharmacy sort of pharmacists, their classes and their lecture theatres were kind of co-located with the med building. And also they had like really long, like us, they had really long like semesters. So we were always, in it together. The pharmacists and the doctors are like just go hand in hand. But it's just so strange that even though the GP practice is normally like right next door to a pharmacy or across the road, we don't tend to like pop our head in and say, oh, hi, what you're doing? Like, even before I started this, I wouldn't know the name of my pharmacist, the local pharmacist. I just wouldn't know. So actually, it's good to pop in, and even you can onboard them. Oh, have you heard about this service? Can I come and do a private clinic in your pharmacy? What are your patients? The pharmacies or pharmacists, they know their patients. They're there, 6 or 7 days a week, and they're seeing their patients, and they're understanding what their patients are requesting. Can I have this? Can I have that? Some pharmacies actually call me and say, actually, a lot of the patients are requesting TRT. Can we get a GP that does TRT? So actually, it's good to just have these conversations and just make yourself known. So it's just strange that actually we're always together, but we're actually very far apart. So just kind of have a chat with them and onboard them. You can literally just tell them, this is Thanks Doc. If you go onto our website, there's a pharmacy partner page. They can sign up if they want you to be the GP in their pharmacy. Otherwise, they can just signpost patients. So they can just basically embed a booking link onto their website. So it's very, very easy. Thank you. Okay, and I think we are at the end. Can we work from home for private online clinic? Yes, you can, and a lot of our doctors do. So you can work from home. So I'm reading the next message, and I got distracted, even though this person got distracted. So when will these sessions recorded on YouTube got distracted and missed a few sections? No worries. I'm always distracted. Even one point I was like, oh, someone's messaging me on the WhatsApp number, like one of you guys, and I got distracted and I missed something that Dr. Bumi said. So I'm going to try to upload it tomorrow or Friday or over the weekend. So they're on pretty quickly. With CQC, usually if you add a location to your CQC, you have to inform them, and this may trigger inspection. If we open a private clinic, would we need to register the location? So that's a good question. So in general, so we are not covering location. So CQC covers activities. So they don't cover location, because actually a lot of people say, oh, I'm going into this building, it's CQC, and therefore I'm covered for CQC. So it doesn't trigger an inspection. We're not registering your location. We are a mobile service. So our CQC follows us. So our CQC is regulating the services that we provide. So what they're looking for in terms of the clinical governance, they're looking at the patient notes, the services, the pathways, the policies, SOPs, all of that stuff. So we don't really work in a way that actually, if we go into your pharmacy, then that triggers an inspection for the pharmacy. No, we're almost like, for example, if you go into somebody's home to provide, do a consultation, to do a home visit, that location isn't CQC. So that's sometimes how I break it down. I know it sounds silly, but that's just almost the most simple way to think about it. Because we're mobile doctors, mobile service, the service that we're providing is mobile. because whenever we start up, especially with private clinics, and when you sign up to be a private clinic, we discuss, you have an interview and we go through the criteria. So we don't want someone who has, this is really for startups. We don't want a very established doctor who has a 1,000 patient list coming in and he's going to be there 9 to 5, Monday to Friday. No, that doesn't, because that's almost like you just need your own CQC registration. We're almost doing it as if, okay, you have the practicing privileges. We know that actually in the first 2 months, you might not even see one patient, and it might just be as and when you have a patient. With all businesses, is as and when you're starting up. So you might not be able to book like a full patient list for a day. You might just say, okay, this patient coming at 2 o'clock, this patient coming at 4 o'clock, and you're back and forth. So you're still a mobile doctor. So good question. And I think that's the end of our questions. And we have finished kind of on time. So thank you so much, everyone, for joining us today. I will put this webinar on YouTube so you can have a flick through and have a listen back. Also, I've left in the chat our number for WhatsApp, or a link for WhatsApp. So if you have any questions or privately, you can message me. We are having our next cohort come through next week, or in 2 weeks' time, our next cohort. So if you want to have any information about that, or being on the cohort after that, then just message me. Also, if you join our newsletter, the link is in the chat. You'll get all the information. So I think automatically it triggers to send you information about private clinic and Uber doctors. So if you have any questions, you can have a look there, and it has links to our platform, etc. If you wanted to sign up. So thank you so much, guys. You have been an amazing audience, and we'll be back again in 2 weeks' time with more stuff, with more partners, and with more info. So have a great evening, and I will speak to all of you. I'll see all of you soon. Thank you. YouTube channel is at thanks.uk. At thanks.uk.